Hey everyone, welcome back to the Energy Blueprint Podcast. I'm your host, Ari Whitten, and today I have with me Dr. Miriam Rahav, who is a triple board certified physician in the fields of internal medicine, hospice, and palliative medicine and functional medicine. That sounds like 15 years of training or something really remarkable.
Yeah.
Dr. Rahav is also certified in acupuncture through the Tri-State School of Acupuncture, and she's currently training, as if all of her past training is not enough, she's currently training in a diagnostic and treatment modality called autonomic response testing through the Klinghardt Academy. So yesterday, actually on Facebook, she made a post and tagged me and a group of 20 or so other people in the health space and doctors and other people with a platform who are health experts, and she shared some really fascinating stuff. She is a doctor on the front lines treating people with coronavirus, and she's doing it with some really novel therapies beyond just kind of what's going on in standard conventional hospitals. She's really experimenting with some stuff, based on logical speculation on some of the mechanisms of action of how some of these things might work. And they're getting great results. And the goal of this podcast and of this conversation is really just for her to share what she's been doing and hopefully advance the state of care, maybe have people do some research on some of these things and advance the state of care as far as what these patients are receiving. So hopefully we can help find more effective treatment protocols. So welcome to the show, Dr. Rahav. Such a pleasure to have you.
Thank you so much, Ari. Thank you so much for being there and being a voice, spreading information, light, empowerment, and information. It's really exciting to be asked, and it's very honored to be asked to share my experience with you and your listenership today.
Awesome. Well, it's my pleasure, and the honor is mine. And in that vein, I want to say, I mentioned this to you before we started recording, but just how courageous and it is, I think, for all of these practitioners to be on the front lines treating this, knowingly exposing yourself to patients who have this virus, and doing it in a way where you're being exposed to very high viral loads. You're being exposed to a lot of the virus potentially, which makes it actually much more deadly. And so I just want to applaud you and thank you for that work. I think it's amazingly important and heroic. So thank you for the work you're doing. Before we even get into any of the questions, I just want to express that.
Thank you so much. I thank you for that. I also want to, give a shout out to all my brothers and sisters in arms in healthcare providers across the continuum of healthcare providers, all those people who trained with me and supported me, all the nursing and all the transporters and all the phlebotomists and everyone who made my life brighter and better. They're all in hospital, and I think differently from what I'm about to share with you, are not necessarily kind of armed with the same tools that we hold within the integrative and functional medicine space. And so I want to share that, we in the functional and integrative medicine space, I'm standing on the shoulders of so many giants in medicine who have created these treatment protocols, who have experimented with ozone and with IV vitamin C and with IV hydrogen peroxide and all these tools that we know and have tested previously to be strong antiviral tools. I feel like I've honed my clinical skill around viral illness for many years. And so that when this clearly became a clinical entity that we would be grappling with, me and my team felt like we were prepared. I think there are nuances to this particular clinical entity, which we can go into, but overall we feel like, not with hubris, but to a certain extent, like we've been here to some extent, and therefore we can do this. We needed to prove it to ourselves, of course, and then we are proving it to ourselves. And so I feel like our sense that it would be possible to address this effectively and then actually address it effectively so far, and I can talk about caveats and nuances within that. But I think that's different from what's happening in hospital medicine, where my colleagues are actually affected, where they're actually infected, where they're actually dying right alongside the humans that they're treating. And that, I think that's part of why I felt so compelled to raise my voice, because all of us healthcare providers have signed up to alleviate human suffering and to live a life in service. And part of what training is to run towards that thing that your lizard brain would have you run away from, right? So, and that's true when someone codes, or when someone is vomiting blood, or if someone is having a seizure. The lizard part of us wants to run away, and then the medical training part of us reconditions ourselves to run precisely into the problem the way firefighters will run into a fire. It's a conditioning and training that's part of what our medical training across the continuum of health professions is for.
Yeah.
And so I just want to give a huge shout out to all those people who are actually materially in harm's way and have been harmed.
Yeah, beautifully said. So what is your experience like right now treating patients with coronavirus? What's going on in your clinic? What are you seeing, and how does this differ from, maybe the flu, or kind of other viruses that you've dealt with in the clinic previously?
So I think the bottom line for all infectious illness is that on a cellular level, it's anaerobic. And so we know that tools that increase oxygen tension in the body are going to be antiviral tools. So it's not common practice to use ozone in the United States, but ozone has been proven an effective antimicrobial. I say antimicrobial because it's broad spectrum. Also therefore, and this is kind of another offshoot, we've been using these tools, for example, in our practice as a complementary treatment for cancer, because we know that or proponents of understanding cancer as a metabolic disease are also figuring out ways to heal the mitochondria, and part of that is increasing oxygen tension. And there's interesting work around that. So all of those things I just think are kind of circling our understanding of how we would then deal with a viral illness. Specifically, the excellent question that you asked about how coronavirus might be different from influenza viruses is the fact that it's novel in terms of our immune system exposure and our immune system's ability to rally a response, A, and B, it seems to be working specifically at the level of the heme molecule. And so that that corona is binding to the heme molecule and dissociating the iron, which is part of how the heme molecule at the level of the alveolus, which is the functional unit of the lung, where we're actually getting oxygen and carrying it out through our circulatory system to our tissues. It's leading to a dissociation on that level, so that we're actually dealing with two things. One, lower oxygen saturation, which frankly makes you a better host, because remember, all viruses are anaerobic. And so the lower the oxygen tension, the easier it is for any infection to thrive. And two, also, the offshoot is these kind of rogue iron molecules, which are leading to a lot of inflammation, oxidative stress in lung tissue. And so what we're seeing in terms of what that means when people are coming in is that it's almost like an altitude sickness, if anyone has experienced that, in terms of that feeling of air hunger. And I think depending on someone's fitness, or we can think about this different way, let's say fitness or conditioning, or on a cellular level, I'm thinking about the mitochondria and someone's ability to make ATP, which is the fuel. Oxygen drives that. And so people are describing, the lack of that. So if you've ever exercised maximally until you feel like burning and aching, people are describing muscle aches and bone pain. I think that's different. I think in the flu, you'll experience what we call myalgias, or an achiness in muscles, but people are hurting down to their bones. And they're weak, they're incredibly weak. And this is also leading, I think, the body's trying to overcome the oxidative stress of that rogue iron molecule, or the many rogue iron molecules, At the level of the lung, the lining, there's a special lining of the alveolus, again, the functional unit of the lung that helps, it's called surfactant, that helps it open and close. So that it doesn't stick, because it's like a little mini balloon. And that is usually as a surfactant is rich in vitamin C to kind of manage the usual oxidative stress associated with breathing and oxygen exchange at that level. But the body's antioxidant defense is overwhelmed. So I think that's one mechanism we're finding where IV vitamin C, or vitamin C orally, first of all, is helpful in both preventing and then maybe managing some of the more mild syndromes. The people who are showing up in our office are sicker, right? So they frequently have tried to manage this at home. They're trying to shelter in place. We are all dealing with the overwhelming amounts of fear-inducing information, terrifying information that's on the media. And so coming here kind of as somewhere, some of them have actually been rejected by hospitals because they haven't desaturated well enough to kind of qualify for admission in the hospital. So they're hovering in their oxygen saturation, around the 90s, some of them 88 to like 93. Officially, I think we're qualifying for hospital admission when we dip below the 90. And so are coming in here quite deconditioned. And so that's different, I think, and maybe we'll want to tease out what I'm recommending for people at home versus what I'm seeing clinically in office. But the bottom line is that when we're using the higher doses of vitamin C, we're actually, hopefully, I'm sure that the body is recruiting some of that for antioxidant defense. But when we're getting to those higher doses that we're getting to at the 20 gram level, which just to translate that, if we're taking pills, we're trying to hit maybe 2,000 milligrams a day, and what we're doing IV is closer to the 20,000 milligrams, and we're modifying that. So we can talk about that, like some nuances, but we're actually leading to a pro-oxidative state where that's going to translate. The bottom line in the body is increasing oxygen tension, and that's where we're getting some of that antiviral activity that's related on increased oxygen tension in the body. So I think that's a little bit confusing for everyone.
So let's clarify that. I think there's a lot packed in there. So normally vitamin C is an antioxidant.
Yep.
At lower doses. Yep. At these higher doses that you're talking about, it actually becomes more of a pro-oxidant, but right. The goal is for it to be a selective pro-oxidant where it's specifically delivering free radicals to the virus. Is that accurate?
Let me see if that's accurate. The way I understand it is that vitamin C at higher concentrations winds up cooling a little bit, like it's more than the body can process, and will kind of cool around the cells and be converted into hydrogen peroxide, and actually then be converted into oxygen, deliver. It's kind of it's almost, I think I understand it as more of like an extended release oxygen delivery system. Mm-hmm. Yes, in the sense that, and this is something I'm also trying, I think that, most of the time I'm at the point of care, and I've been trying to kind of beef up my own kind of mechanistic understanding of oxidation and reduction. On a mechanistic level, my understanding of neutrophils and the way they work is when they engulf a bacterial or viral particle, the way they're working is by stealing electrons and electrically destabilizing a pathogen. And that in order to do that, we need free electrons. Mm-hmm. And that vitamin C is also an electron donor. And I think that's also what antioxidant means, like right. An electron donor. Yeah. And so I think that's one mechanism.
Mm-hmm. Got it. So I want to address your thoughts on policy, but before we get in there, you mentioned the heme and the hemoglobin aspect of this situation. This is kind of a newly emerging model.
Right.
This situation. There still isn't a ton of research on it. I did a podcast in last week's episode talking about this in depth, talking about also the potential of methylene blue, and especially methylene blue combined with photobiomodulation from red light therapy may be an effective tool for inactivation of the viruses. Just yesterday or the day before, there was an article published by a young guy who's a new MD, PhD, who put out this article basically saying, debunking the hemoglobin, iron hypothesis of COVID-19. And I read the article, and more than anything, it was just saying like, hey, we don't have enough evidence to say, I mean, the real argument was we don't have enough evidence to say that this is going on in COVID-19, but he framed it as, kind of as, we have so much strong evidence against this hypothesis that we can completely debunk this and discard it. And I think that framing of it was totally inaccurate. I think it's totally accurate to say, hey, this is still early evidence. It's somewhat speculative, but things seem to line up with the clinical picture.
Yeah, I think that's the best way of saying that. Things are lining up with the clinical picture. So you're seeing a disseminated bilateral pulmonary process, right? You're seeing, and what I'm describing is kind of like a broad clinical picture of like a low-level hypoxia, right? So like, why are people's muscles aching? Have you never worked out? Have you never climbed a few flights of stairs and kind of hit your maximal level of fitness and feeling the burn? Like, what is that? Right? That's like burning through your ability to like for aerobic metabolism, and then you start kicking into anaerobic metabolism and lactic acid production, people. Like, this is like common sense. I'm literally sitting here at the point of care and listening to what people are saying.
And so you're, just to clarify for people listening, you're saying that anaerobic metabolism, that muscle burning effect, is a result of the muscle cells shifting into anaerobic metabolism, where they're producing more lactic acid as a result of oxygen deprivation. But
and therefore achy.
Right. But instead of happening as a result of like high intensity exercise, it's happening at rest, which you're saying it lines up with this explanation of low oxygen levels.
Exactly. Common sense. This is not new physiology. So like, in some ways this is novel, but this is like common sense, like basic like physiology. And also I think what's happening here is that a lot of people are reporting nausea. And so that this is really burdening the liver. And I think that furthermore is when people are nauseous, they're not eating, and I think it kind of leads to this whole cycle of decompensation.
One quick thing, the argument put forth by this guy was basically saying it's probably not attacking the hemoglobin on red blood cells. It's probably just damaging the lungs, and that's causing the low oxygen state. Do you have any thoughts on that, and why you think?
If that were the case, then why would people repeatedly have dysregulation of ferritin? Okay, fine. No. Let me qualify that, because ferritin acts as an acute phase reactant. But I don't think we've seen it go into the thousands the way we see it right now. I mean, and I think the jury's still out. Expecting us to have a complete laboratory understanding of what's going on while people are actively dying in hospitals is a little bit far-fetched for me. Like, this is a time to take care of people who are in distress. Don't ask me to be responsible for a randomized double-controlled trial with all the laboratory assays and so on and so forth. I am a clinician at the point of care who is daring to stand up and say, let me try and help you, because that is my professional mandate. That is my ethos. And so far, let me tell you, so good. And that is really awesome. It's really awesome. It's joyful. It's hopeful. It's empowering. And that is a message that we need to share, because this fear stuff, I can tell you based on experience, past experience, I can tell you, I came into medicine through the Thai AIDS crisis. I happened to be in a place and time, and the first response of the Thai Ministry of Public Health was well-intentioned, but they sent out in a huge media campaign pictures of end-stage AIDS, and it led to isolation and stigmatization of the humans precisely in the moment they needed help the most. And it's a similar thing for me. This is like deja vu. It's like people who are sick, we're gonna run away from them. No, I'm going to step forward, because that is what I signed up for, and I'm going to do everything possibly within my power, especially when we look at the harm benefit ratio. How much can I possibly hurt people by giving them an IV bag with nutrients?
Yeah. I love it. And thank you for expressing that. I think it's such an important and powerful message. So,
and it's working. And that's the other thing. It's working.
Yes. I want to get into some of those specifics of what exactly you're doing. First, you mentioned, you kind of alluded there to kind of what the government, what the media is doing. I'm curious what your thoughts are on, if you were making decisions at a policy level, what would you be doing differently, if anything, than what the government and the media, I guess, are currently doing?
I think that, right now what's happening in my practice is that on a policy level, if we pulled our collective wisdom in the spirit of true scientific inquiry, the first thing that we do when we think is something working, that something might be working, is we reproduce it. Right. So I'm a single operator and I have an amazing team, but we're just a small boutique clinic in New York City. What would happen if we took exactly what I was doing and reproduced it at the hospital level? That would be something that would be worth pursuing, where there would be a greater ability to monitor and actually collect both clinical and laboratory evidence and scale what single operators like me are doing. What could be the harm in that? And also, boots on the ground. If we look at what's happening in hospitals, are we seeing acceptable clinical outcomes there? Who are the medical authorities guiding policymakers? Who are they? Are we looking at them and any conflicts of interest they might have in promoting one therapy or another? And I can't help but ask those questions because in my medical training, coming from a background where I was really interested and kind of cut my teeth in terms of becoming an integrative practitioner in the time of the AIDS crisis, where there was a lack of pharma available and people banded together in the areas most severely affected by HIV/AIDS in the upper north of Thailand and said, what are our own resources, and found plant resources and found spiritual resources. So, I've been in a situation where we didn't necessarily have the answers, but we cast around to look for them and banded together and amplified our voices. And I think that this is such a time where we can't have all the answers. That can't be the expectation, but that we can pool our resources and we can, in terms of what's working, why can't doctors like me be involved in sharing my voice to policymakers and saying, maybe this is cheap, people. This is cheap medicine. We're ordering more ventilators. I don't need a ventilator. Just why don't we just buy some vitamin C for, this is like the cost is infinitesimal compared to what we're spending, or we're saying, let's get some convalescent blood and spin out immunoglobulins. Those are so resource intensive. Why wouldn't the motivation to be to spend less and find better clinical outcomes? Why isn't that the dominant paradigm? What's going on here?
Mm-hmm. One quick question before we get into that. The media, this is kind of an unprecedented thing, at least in my life, I think in anyone's lifetime, as far as any sort of infectious disease epidemic that has taken place during the era of such widespread travel, such widespread news circulation and news watching, and the ease of availability of news, and especially the internet, where we're all, touching the internet via our computers, via our phone, multiple times a day, if not hundreds of times a day. We're constantly getting updates. It is all over the news, nonstop, coronavirus pandemic, this many deaths, hospitals being overwhelmed, people are dying. I
challenge the media to pick up my story. I challenge the media to promulgate messages of can-do, hopefulness, and in fact are doing successfully. If we talk about human interest stories or feel-good stories, this is a feel-good story. Humans who come here asking for help leave feeling better, and we call them the next day and they feel great and they're so happy, and they're sending in neighbors and cousins and brothers and sisters. Why is this story not blowing up?
It should. And hopefully people listen to this podcast and maybe some media outlets will.
I hope so.
Do a story on it. I hope so too.
It would be better for humankind. And I think the role of the media is that I don't think ever before the media has been acknowledged as playing such a huge role in public health. And that, of course, can be like anything else. With great power comes great responsibility. And always journalism has been focused on not being biased. And I think that this invites all of us to become critically literate and just look for the possible. I'm not saying yes, but is there a possible bias here? And if so, how can we address that? And how can we as journalists, the way I also try to be unbiased as a physician and not be adherent to one form of therapy or another. You know, one of my teachers, one of my favorite sayings that he has taught me is the truth is what works. You know, and so, you know, I think sometimes we fall into traps. For example, me as an integrative medicine practitioner, well, if it's pharma, then maybe I won't like it as much because it's pharma. No, if it's pharma and it's appropriate and it's judicious and it works, then pharma it is. And if it's a natural supplement, or if it's a nutraceutical, or if it's a food-based strategy, or it's a dietary or lifestyle intervention, if that's what works, then that's it. The truth is what works. And try to examine the tools in our toolkit. I think the point of integrative medicine is an expansion of the toolkit. And truthfully and frankly, in my 4 years of medical school, I had a 2-hour lecture that was elective and that I wasn't graded on in nutrition in 4 years of medical training.
Well, a lot of schools, I think, don't even get the 2 hours.
Exactly. And that was like a good scenario.
Yeah. So let me ask you this. There are a lot of people right now who are feeling like, you know, we have these lockdowns. There are a lot of people who kind of feel like, I'm just going to stay home, isolate myself, hope I don't get this thing, and wait as long as it takes for them to develop a vaccine. And that's the answer to this thing. And if that, you know, hopefully it'll come out in a year, maybe 18 months at the most. I literally know some people that are saying, you know, that their intention is to stay home and isolate themselves until a vaccine is available. And that's kind of, you know, it seems like certain people like Bill Gates, for example, are kind of wanting to push for that sort of interpretation of what's going on right now.
Which is why I think we need to be critically literate and ask ourselves, who stands to profit from kind of the all the media, which is literally focused on infection and death toll and the lack of equipment. It's like this doomsday news reporting. And I'm saying something completely different. I'm saying with a couple of readily available and cheap tools, I am able to bring people who have been very symptomatic, very sick, and even, might not have made it, and certainly, we're headed towards the hospital, and they're literally turning around in a day. I'm not saying cured in a day, because sometimes we have to do a little more. In a few cases, we've actually repeated an IV therapy. So 2 days, 3 days, but they're back to themselves. They're eating, they're at home, they're happy. They're calling us up saying, thank you for being our guardian angels. And it makes us cry from joy.
Let's say there's skeptics listening to this, who are, conventional medical doctors. As you're a conventionally trained MD, but let's say there's conventional MDs who don't have any of your background in functional medicine, in nutrition, in lifestyle therapies, in integrative medicine, and so on, and all these things that you spent so much time training in. And they're listening to this and saying, well, if she's experiencing such great results, maybe it's because she's not seeing severe patients, patients with really severe sickness like we're seeing. And she wouldn't have such good outcomes if she was treating the same severity of patients. What would you say to somebody who's a skeptic that's thinking like that?
I think there are some crossovers in terms of medicine and things that work. So if we're talking about potentially the pathophysiology of the dissociation from iron from the heme molecule, in that case, what's been studied to be effective is that hydroxychloroquine, which seems to work on that same level. And I think the mechanism of action is not completely understood, but it's not completely understood newly. It's an old, not completely understood mechanism. And I don't think the onus is on for me to prove something that has not been completely understood and yet has been commonly used by medicine. And I think that's also like a takeaway from this, is sometimes in clinical practice, we use things that work because that's what we do. And Plaquenil or hydroxychloroquine is one such example that's still within the pharmacological canon. And what I found, for example, over this weekend, I was challenged with with a couple that found me through a word of mouth and got in touch with me. And I wasn't physically in my practice. I was, celebrating a holiday with my family, kind of trying to take a day of downtime. And I was out on Long Island and they were in Newark, New Jersey, and they didn't sound good. And so I said, you know what, let's put this to the test. I called to pharmacies around them. I found a pharmacy that had hydroxychloroquine available. They had each been struggling with symptoms and displayed every sign and symptom that I had already clinically experienced: a loss of taste and sense of taste and smell, bone pain, myalgias, cough, shortness of breath, and a generalized malaise and weakness, a loss of appetite. So that kind of constellation, which screams COVID. I prescribed them to them COVID positive because I had every clinical reason to prescribe and label them as COVID positive. They were able to get the medication around 1 p.m. on Saturday, and they physically came into my office for in-person assessment today. And the myalgias and the pain had largely already resolved.
Wow. And how many days is that, just for people who
So
don't know?
they were 5 doses in. So there are 5 doses in. The first day we do a loading dose of hydroxychloroquine. So 1 tablet is 200 milligrams. So the first day, for people who are well and young enough, for older people, I'll go a little bit lower. So that's 400 milligrams, 2 tabs twice a day. Day 1, those are loading. That's a loading dose. So they had 4 tabs the first day. That was Saturday. They got 4 tabs into their system. Sunday, they had a tab morning and a tab evening. And then Monday, when they came in, they were after 1 tab. So that's a total of 1, 2, 3, 4, 5, 6, 7 tablets.
And just for people listening, we're recording this on a Monday.
Oh yeah. And also with zinc. So I insisted that they take zinc with it. There seems to be a story here with zinc and COVID's interrelationship with blocking the zinc ionophore, so that ability for zinc to get into the cell, and so opening that up with hydroxychloroquine. So I, on the wings and a prayer of clinicians who are smarter than me, I put those things together and again clinically see a response. So what I would say to my colleagues, if this whole nutraceutical, I don't think zinc is so far-fetched for my colleagues. I don't think vitamin C is far-fetched. I don't think vitamin D is far-fetched. These are things that we know and speak to in the allopathic canon, plus a little hydroxychloroquine. And then so far, azithromycin on its own doesn't seem to be doing the trick. The study is of azithromycin with it, but in this case, this was just a clinical scenario where I used the combination of hydroxychloroquine with zinc without azithromycin with clinical improvement based on my understanding, which again is nascent, of the pathophysiology of coronavirus.
I love the emphasis on nascent there. So you've mentioned zinc, vitamin C, vitamin D, hydroxychloroquine.
Mm-hmm.
Is that the crux of what you're doing with these patients? Is there any other things that you want to mention as far as the strategies that you're using that you're seeing good results with?
Yeah, so again, and then higher doses of vitamin C IV, right? And we discussed that could be mechanistically more than one thing at play. What I'm seeing also is that people who are sicker, let's say they're physically coming into the office, I have the luxury of physical exam. And some of the people who are sicker also have, physical signs and symptoms of insulin resistance. So I can see belly fat, I can see skin tags, which is a sign often of insulin resistance, and insulin-like growth factor leads to a proliferation of little skin tags. The name for that in medicine is acanthosis nigricans. We always have like the best names for things that say it 10 times fast. And also a lot of amalgam in the teeth, right? So there seems, we know this, that there is an inverse, at least in the functional geek space, this inverse correlation between toxic burden, or what we would call allostatic load, the sum total of our environmental exposure is a term that's been coined in the functional medicine space, the exposome, and an immune system ability to function optimally.
Yeah. If you don't mind me interjecting, there's some stats. Obviously, we have some stats from Italy, and then there's some recent stats that emerged in the United States. The stats in the United States are that 86% of people who have died in the United States thus far, as of, we are on April 13th right now, are people, I think it was either over the age of 50 or 60 and had at least one pre-existing condition.
Mm-hmm.
And cardiometabolic disease, or cardiovascular disease, diabetes, hypertension are big ones. COPD is a big one as well.
Mm-hmm.
And then in Italy, the numbers are even bigger. It's 99% of people that have died are above the age of 50 or 60 and have at least one pre-existing condition.
Right.
So there is absolutely this very, very clear, amazingly strong link with allostatic load, with the extent to which somebody is already ill, and usually that's connected. I mean, most of these things I mentioned are diseases of lifestyle, which relate to this concept of allostatic load. And so to the degree you've had for many years lots of allostatic load, poor lifestyle nutrition habits, you're then going to start to get some of these cardiometabolic diseases, and that therefore, which then dramatically increase your risk of developing severe symptoms and dying from the coronavirus. Is there anything you want to add to that, or do you disagree with anything I've said there?
I don't disagree with it. I just want to put a little qualifier there, because I always worry about like lifestyle diseases in terms of like a judgment or a blame or a fault kind of nuance, because I feel that really we've been, as a world population, not advocated for adequately, not informed adequately about what is and isn't good for us. I think there's just so much information out there. And I think some of it, for example, we say, okay, well, like fish in deep water, fish are good for your health. They're full of omegas. But what we're finding when I start screening for mercury, aluminum, arsenic, and lead is that people are walking around and they have all these diagnoses. They have attention deficit disorder, or they have depression, or they have hypertension, or they have diabetes, but underlying it, they're poisoned. And that's not their fault.
Yeah.
You know, it's not that anyone's lazy. It's that these things might be happening and they're not part of what we look for or examine or speak to or treat, or therefore, if we see it and it's rampant, like start thinking about what's actually happening to our planet and our food supply.
100%.
Because these are hidden scourges of our time. And I feel like like the amount of suffering that I think is being unveiled by this COVID-19 story is just staggering and beyond painful. And one of the possible silver linings, I'm saying possible because I'm not celebrating anything here at all, is if this creates an opportunity for it to look at these underlying comorbidities and what is driving them, and really think about overhauls of our medical, our healthcare system, which with emphasis on health, you know, as opposed to being reactionary. How can we be proactive? How we can protect our planet, our food sources? What would happen if that was the way we operated? Just from an ethos, never mind the tools, just from an ethos. Let's just start looking.
Absolutely. I mean, what if at a policy level, at a government level, we made more efforts to not accept, you know, eating glow in the dark, you know, breakfast cereals, you know, and other, you know, and donuts and soda and potato chips and pizza and ice cream. What if we didn't accept that as the norm of what an acceptable diet is, and allow that to be the standard?
Yeah, but what if what's making you sick is your farmed tilapia and your glyphosate tomatoes that are GMO, you know, and your piece of toast? You know what I'm saying? What if you're not? I mean, I think like what you're saying, I think might be more readily accepted and understood. But what if your behavior actually nutritionally is impeccable, given your resources, given what you're able to afford, and that you don't necessarily have the resources to grow your own food or be part of a CSA? Or what if you're language locked the way I'm finding that a population that has found me? One chapter of my life was actually living in South America, and I've had this amazing and beautiful South American community living in New York find me. It's like this full circle, but they're, have different media outlets and different resources available to them. And many of them are uninsured. And many of the pharmacies, they're saying just to monitor themselves at home, they said there are no thermometers available. There's no hydrogen peroxide. You know, if I say give a little gargle with salt water and prevent a sore throat from then descending into your lungs. And they're like, we can't find it anywhere. So like, how do we really advocate for people who aren't eating glow in the dark breakfast cereals? Yes, there's certainly a huge amount of teaching and supporting that we need to do, but there's more, and it's more nuanced, it's more complex.
Yeah. Yeah. I mean, I really wonder what, knowing those numbers, as I just shared, 86 and 99%.
They're staggering. They're staggering.
And knowing those diseases that are contributing to people dying from this are directly linked to nutrition and lifestyle, I really wonder how many lives could be saved if we had at a policy level, policies that were more in favor of penalizing some of these food industry companies that are producing products that we know are harmful to our health, and we did more to support the companies that are producing products that we know are good for our health, and we changed what the norm is of what the majority of the population eat, and made it more economically feasible as well, made it cheaper.
Yeah, here, let me think about it this way. So there used to be a lobby in Washington that was anti-GMO labeling, and that lobby dissolved. It dissolved on its own. We didn't go after it because humans, fundamentally, we are interested in being well. We are interested in being there for our children, just like that community of humans, wonderful humans confronting their own mortality in the 90s in Thailand taught me that they wanted to be as healthy as possible, even though they were HIV positive, to live to see their children grow, to try to be present. And if our motivation is here to love and nurture the next generation, as is, I think, the universal human condition, all of us inherently want to be well. I would say, we're here, like the thirst and zest for life, it's programmed into us. We're designed to love our progeny and procreate and create these family units of love and support. And when people learn that GMO might not be good for them, or that eating organic is better, it's the biggest growth market. And all of these companies who were lobbying against this, when they found out that it was no longer profitable to resist labeling, started voluntarily labeling because it was better for business. I think that's the bottom line, that health is good for business. I know that illness has been good for business, but I think fundamentally we need to recognize and acknowledge that treating each other well and being healthy and being vibrant can also be really good for a business's bottom line, a country's bottom line. And that's been something that I challenged myself, because as a medical doctor, I promise you, I have no business training. And it was completely insane for me to decide that I would open my little own medical practice. And I asked myself a question: can I run an ethical business that's based on treating everyone around me really, really well? And I am, again, only 3 years into having my own practice. So you have to understand, from that perspective, I'm a baby. But I asked the question, right? And everyone here in this practice was just as worried about being exposed to the virus, and got just as much of the kind of fear message that's been so pervasive, and had family members question the need for them to show up at the office. And I said, look, this is what I want to do. First of all, I want to show up. It's what I signed up for. If you didn't sign up for this, I understand, because I'm a medical doctor and a weirdo and you might not be. But if you join me in this, all of your IV treatment, your medical treatment, it's on me, because I want to protect you. If you aren't well, we can't do this for others. It's that classic, metaphor, taking the oxygen mask and putting that on yourself, that you're always taught. And like when you get onto an airplane and they go through safety protocols, like we have to have our oxygen masks on. Everyone in my practice got IV vitamin C. Everyone in my practice is snorting up nano ionized silver into their nose and all over their face as a barrier method. Everyone here, to the best of our ability, I'm trying to make meals. We're like feeding ourselves. Like I'm making one pot meals in our Instapot full of like healthy like legumes and vegetables and onions high in quercetin and mushrooms, which are pro-immune, and tons of curry and just like whatever is in my pantry. And we're eating one pot meals together as a practice. It's been delightful, actually. And it's part of like, we have to walk the walk. And guess what? My team feels better. Some of them are feeling better and going through their own kind of health improvements and losing weight as a result of this. Another silver lining. And we're bonding because we're being fortified by our ability to band together. And that's also like, so my team is thriving in the midst of all this because that's been our choice, our conscious choice. And it just proves that a business where like every member of the team is ethically treated and lovingly treated can hopefully, God willing, thrive as a business. I mean, we can talk about this, God willing, a few years from now and check in and make sure that my experiment continues to be successful. But again, so far, so good.
Yeah. So let me jump back to the clinical experience and what you're seeing. So right now in most mainstream hospitals, what they have, to my understanding, is they've got ventilators. There's been some experimentation with some antiviral drugs. I haven't heard about that any of them are particularly effective. And then there's hydroxychloroquine, which some hospitals seem to be experimenting with, some seem to be rejecting. And I'm under the impression they're really, other than that, it's maybe symptomatic treatment, some Tylenol to reduce fevers, and I don't know if they have anything else beyond that.
I think there are different things that are being tried. I think that it seems that all ventilated patients, the mortality rate is really high. So I think doctors are trying to avoid ventilation as much as possible and do high flow oxygen, which actually is appropriate. By the way, just as we're speaking, it's 7 p.m. and every day outside of my window, I hear New Yorkers cheer for essential workers. And it's nice. It's like a really beautiful ritual that's evolved. And I don't know if you'll hear it right outside.
I heard a little bit in the background. Yeah.
Anyway, so I think that, again, there's an evolution there. I heard that empirically, when someone comes in with a clinical picture that is consistent with COVID, people are using lower dose IV vitamin C infusions at 1,500 milligrams.
Why bother with the IV at that dose? I mean, you could easily reach that with.
Yeah, that's a really good question, and they're doing that a few times. I think it more than anything, it's a lack of familiarity. It's always scary on a human level to just make change or to accept change. And I think in some ways this is why a crisis invites us to evolve our understanding of what's necessary, whereas otherwise we might be conservative. And at the same time, speaking of conservative, if we were able to just push the envelope on vitamin C a little bit, I want to emphasize that vitamin C at higher doses can also induce kind of increase the body's ability. Suddenly it gets that oxygen and it starts working and starts kicking out, it's like this idea of detoxification, which is more of a functional integrative concept because of my beloved, I want to say my dearly beloved allopathic trained and brilliant colleagues are like, well, we're always detoxing. That's what the liver is for. That's what the kidney is for. And so I think there's a fundamental paradigmatic difference in our understanding what toxicity in the functional integrative medicine space is. And I haven't been able to bridge that divide, truthfully, even though I have tried to do that a little bit by just a little more testing. So I am able to look at glutathione levels. I'm able to look at vitamin C levels. And kind of speak a little bit. I look at CoQ, I look at carnitine, and this is my routine testing. Plus I screen for arsenic, aluminum, mercury, and lead. And I'm able to document one, higher toxic load in heavy metals, and two, a reduced antioxidant defense. And so these are things that I'm able to look at routinely that kind of help me bridge that divide and speak to, and then when I treat it, for example, where I'm reducing mercury and I'm increasing antioxidant defense, a lot of clinical symptoms resolve. Things like, blood pressure gets better, liver enzymes normalize, brain fog goes away, attention and cognitive function starts returning. So periods come back, menstrual dysfunction and amenorrhea. Anyway, so I think that's something that I'm working on doing on a daily basis, and that this is just kind of like a poignant or urgent kind of dramatization of that ongoing kind of paradigmatic chasm, and that this situation begs us to bridge that a little bit better.
Yeah. So, in mainstream hospitals, they've got those tools that I mentioned. The ventilators have been a big focus up till now that attention is shifting away from those as people are seeing very low survival rates.
PPE, right? So
right.
That's been another. And so like, here, yes, we have all the masks and we ask people to come in because it's also like we have to play our part, but we're also doing a little bit of the alternative barrier methods. Oh, it looks backwards in my camera, but
the silver gel for people who are not watching the video. So at your, is it correct to say hospital, at your private practice, at your clinic, you have I assume you don't really have ventilators, or it's not
not at all. So we are a community-based clinic. We don't have the resources, right? Because ventilators requires expertise, right? We have respiratory therapists, we have ventilator settings. As trainees in medicine, we have to familiarize ourselves, like all of us internists rotate through the medical intensive care unit and have to have a basic familiarity, but it's really intensivists who are monitoring and respiratory therapists who are monitoring. There's anesthesia that's required because being intubated is incredibly uncomfortable, so it requires sedation. And all of these things require intensive 24-hour care. And us, as just a few operators, like we don't have the staffing to be able to support 24-hour monitoring. This is not the appropriate setting. No, we do not have ventilators, nor should we.
And so that last point is what I wanted to get at. So do you think you need ventilators? Like if someone's coming in to your clinic, they're sick, they've got COVID-19, they've got lower oxygen saturation levels, they're, let's say, in the low 90s, let's say they're in the 80s. Do you, maybe even high 70s, I don't know what the numbers are you're seeing, but do you immediately say, hey, I got to refer you out to the hospital to get on a ventilator? Or do you say, hey, I've got these tools with IV vitamin C, with some of the other things that you've mentioned, and I'm confident that we can get your oxygen saturation levels back up and get you better without the need for a ventilator and this is an important point, in scenarios where the conventional hospitals might actually intubate people or put them on a ventilator?
Okay, so that's a really good question, and thank you for asking. So the answer is, if someone is coming in and they look like they're like respiratory decompensation and they're saturating, you said, depending on what I'm seeing, low 90s, high 80s, has it gone down to the 70s? And am I saying, I've got this, we can treat you here? Or, what am I doing? Am I recommending them to a hospital setting? And so I guess the frame for this answer is that I, regardless of being an integrative medicine physician, I'm also a medical doctor who took the Hippocratic Oath. And the Hippocratic Oath states, first do no harm, primum no curare. And I am personally, of course, and ethically and professionally mandated to look out for any human who I'm honored enough to be able to care for's best interest. And that means that they have to be safe. Of course, if someone isn't qualifying for hospital admission, meaning we've had many scenarios where people actually show up and they're like, please take me. And the hospital's like, listen, you don't qualify yet. Your saturation is still too good. That's a perfect person for me because they still feel very unwell and they don't qualify for hospital admission. And that's kind of when someone is safe to be in my court, and like putting little ear mark that you won't be able to see on the podcast, but like my little rabbit ears, like, safe to be in my court. And that is generally how I operate. If someone comes in with intractable abdominal pain, if they've already been scoped and they've already had all the gastroenterological appropriate assessment, and they can't find any reason for their intractable abdominal pain, that would be a good case for me to try to work on. However, if they have some, mass that needs to be removed or examined or diagnosed, or if they have some bleeding blood vessel or a giant ulcer, that's why I have my colleagues. That's why it's an appropriate hospital referral, appropriate referral to a colleague, and that everything needs to be done in the best interest of a human coming in for care. So the answer is that the people that I've seen, if they are satting too low and they're in danger, I think of respiratory decompensation, I have to refer them. That's why acute care exists. That's the whole point, and why I'm so grateful to my brothers and sisters in arms and hospital medicine for doing the incredible work that they do, and my hat is off to them. I'm here in the community to pick up and carry the humans that don't qualify for hospital admission, keep them well in the community and away from the hospital, away from burdening the hospital. And the more successful I am in doing that, the more I'm supporting my brothers and sisters in hospital medicine.
Yeah. I also think it may be worth adding, I'm curious if you agree, but that because the survival rates on ventilators are so low and really disheartening, that it seems like the only real way that we're going to save a ton of lives is not by fixing the shortage of ventilators, but of course that should be done. But really to save a lot of lives and make a huge difference, it seems like the key is going to be intervening upstream before people get to that level of severity of sickness where they require being put on a ventilator, which is exactly the kind of people that you're seeing. So in that scenario, in less dire, really end stage, super severe cases of this where there's no choice but to put them on a ventilator, in those scenarios, do you think that your approach and your methods that you're using would save a lot more lives compared to what's taking place in most hospital treatments right now?
I mean, I think that's still conjecture, but that seems to be what my experience is teaching me, is that people are doing well. And also people are doing well after struggling at home, trying to heal using whatever they have available at home and not successfully doing so. And so they're decompensated to a level where it's still safe for me to treat. We've had, I think, a few scenarios where we said, this is a little borderline, and you might qualify for a hospital. I mean, if someone clearly qualifies for hospital admission, I will not hesitate and say, listen, this is not right. Like, this is not safe for me to treat you in the community. If if you're treated there and come back, then, that's fine. But yeah, the more that I am treating this, once people have been struggling on their own and not getting through it, and then successfully get them through it in a relatively short amount of time, the more I think that we might be able to extrapolate that experience to kind of say fairly that we can really save lives. That seems to be approximating. Again, I have to stay humble. It's not like I have these thousands and thousands of humans that I could say this for. I wish it could be scaled to a larger clinical setting where my colleagues could help me prove this point on a scale and say we didn't wait for someone to be in a decompensated respiratory state, but accept people and figure out a way to use hospital facilities and hospital rooms to reproduce something akin to what I'm doing here, and see if we are able to keep people away from needing the ventilator, keep people away from needing high flow oxygen, and also, like, another outcome marker that we can look at that's kind of factual and concrete is just days of hospitalization. So if someone comes in there decompensated, how long for them to recover? Never mind the clinical symptoms, but just how long for them to come in and then just walk out on their own 2 feet.
Got it. So 2 final questions for you. One is, if you were in charge of what all of the hospitals in the US right now are doing as a standard protocol to treat patients with COVID-19, what would you have them do? That's my first question. And then the second question is, to everybody listening who is at home, who is maybe potentially already somewhat sick in an early stage, or hasn't gotten COVID-19 yet, but might in the future, what would you say to them to help protect them and bolster their health and their immune function to help avoid getting severe symptoms and dying from this?
Okay, so those are 2 really big questions.
Let's piece them apart. Let's just completely separate them.
Okay, so when we're talking about a policy level, this is something I think about a lot. I think about how to affect change. for me, with a background as an educator, I always think about medical education and how we raise, but that's kind of a longer term. I wish that all the incredible science that I was able to learn through my functional medicine training could be incorporated into mainstream medical education. It's a really deep, scientific, biochemistry-based systems approach. And I think that would also kind of prime, I think, the brilliant minds that go into medicine to bringing more of the science back into medicine and less of these protocols, which can be a little bit rigid and not, I think, not tailored enough to the true complexity that each individual challenges us to really understand and accommodate to. So that's one, the medical education piece is something I think about a lot. I think,
so more than 2 hours of nutrition training.
more than 2 hours of nutrition training. I think when you just spoke a little bit about my bio, it implied many, many more years of study, and that might be really overwhelming, but at least kind of an introduction to that. And what I say to people is that I'm a specialist, and you wouldn't doubt the qualification of someone who, let's say, is an immunopathologist who, is highly, highly specialized at looking at tissue samples and stains and really being able to identify, like they're so specialized and they're so amazing at what they do. I'm also incredibly specialized, and I think have earned, a certain level both of kind of theoretical competence through my studies and also clinical competence through my daily practice, and would love for us specialists in functional medicine to be able to serve as a resource for community because we've been trained to do so. And in fact are able to act. So, I think on a policy level, acknowledging functional medicine as a subspecialty and allowing insurance reimbursement for the services that I give would open up, I think, accessibility and allow more people who are interested to be able to access this as opposed to it being currently more of a private enterprise. I think looking to projects such as the Cleveland Clinic, where they're incorporating functional medicine as part of the Cleveland Clinic, and came out not long ago with an article in JAMA about following a group that's randomized to Cleveland Clinic and functional medicine care versus non-functional medicine care and improved clinical outcomes is a really exciting and important step in the right direction. And I think you're part of that, Ari, in giving opportunity for professionals like me to tell our story. So I think those are all, so medical education, reimbursement, coverage for these services, and acknowledgement. I think a larger public acknowledgement for our expertise.
Yeah. In terms of specifics, like let's say you could not affect policy in a broad, long-term way in any way, but let's say starting next week, in a few days from now, you had the opportunity to say, hey, all physicians on the front line treating COVID patients, here's the strategies that you should be experimenting with. What would those strategies be?
Okay, so I think those strategies would be, it seems to be safe to push the envelope a little bit on IV nutrition. It would probably be safe for everyone to get 7.5 grams. I'm including the pregnant women I've treated with COVID who have tolerated 7.5 grams of IV vitamin C with some calcium gluconate, some sodium bicarb. I can think about it's basically, I think, like a modified Myers cocktail, put some magnesium sulfate in there. If we're able to put a little taurine in there, I think, to support the liver, and universally people would tolerate probably 3 cc's of glutathione as a push, and just have that be the standard of care where someone doesn't feel well and comes in and you have presumed COVID and you get that right off the bat, even as you're gathering, right? Like the same needle that goes in to give the IV, first you can grab a few tubes of blood too, and you can do the swab. So like you can do those empirically and see what happens in terms of clinical progression to the need for high flow oxygen or to the vent, and see how that changes the clinical trajectory of people walking into the hospital.
Do you think there's a place for hydroxychloroquine
And the other thing I
zinc?
was going to say is I think that the low doses, because there's QT prolongation, there's visual fields, there's a lot of clinical concerns associated with Plaquenil or hydroxychloroquine that are generally associated with long-term use. When I'm looking at the literature between 2 and 5 years, Plaquenil is accepted, for example, in women with autoimmune, either rheumatoid arthritis or lupus in pregnancy. So, if we're allowing things in pregnancy, it generally has a more benign safety profile. And certainly if we're looking at like the 7 to 10 day course that we're looking at here, I would say, given the mortality rate and the resource intensivity of the current clinical trajectory of COVID in hospital, that it would be well worth, if I was on a hospital admin level, saying, okay, let's really check this out, because we probably couldn't do worse than the clinical outcomes we've already seen, honestly.
Got it. What would you say to people who are not sick right now, who are at home, but may get this in the next several weeks or months? What can they do? What would be your top recommendations to optimize immune function?
So I think there are a few things in terms of basic immunity. One of the things that's kind of the bedrock of our clinical protocols here have to do with binding, so binding of toxins. So we use widely here either some chlorella or some combination of zeolite or modified citrus pectin, because all of us are dealing with a good amount of environmental toxins, and so reducing those. Glycine and taurine across a general population are amino acids that are essential for liver pathways, and we know that glyphosate might interfere with glycine metabolism, and so those at low levels, and also incredibly cheap, right? So those are safe things to put into your regimen to kind of prime your body for wellness. And then most of us could do with a multi-mineral, and we can think about that from a nutritional perspective. So we can think about, celery and carrots and onions and parsley and other green herbs that are more nutrient rich, or maybe like a trace mineral drops, or we can think about it as an actual supplement. Also tends to run really cheap. I know that trace mineral capsules that we use run anywhere between kind of like $9 and $13 or something for a bottle that will, if you take one multi-trace mineral supplement, because we're all minerally depleted, and that's also, we can parse it out into like iodine and zinc and magnesium and selenium, but those are actually key, and those are ones that across the board, when I usually establish care with people, they're low in selenium, they're low in zinc, they're low in iodine. They're low in magnesium, or if they're not overtly low, they're suboptimal. And so those are all key pieces to immune function, and would be safe probably empirically mostly across the board, especially in combination with that basic liver support, let's say taurine, glycine, and some kind of a binding agent, be it activated charcoal, be it some zeolite, be it modified citrus pectin, be it chlorella. Of course, I have brands and things that I trust more and kind of lean on, but lots of good options out there. And then on top of that, right, so that's special in kind of my functional medicine geek out foundation. On top of that, everything that we're hearing, hopefully that's more mainstream. Vitamin C, yes, yes, yes. Zinc, yes. Again, it's that blockage of the zinc ionophore that seems to possibly, again, emerging understanding of the viral pathophysiology of COVID. And then in terms of our herbal arsenal, it's really, really huge. And so I remember a long time ago reading about lomatium, which is a commonly used anti-influenza herb, and the history of the Spanish flu, which killed so many millions of people, 50 million death toll around the world, anywhere in estimation. There, we don't have exact numbers. The media there served an opposite role, not wanting to discourage people as they were going through World War I and keeping kind of tabs on everything. And so, I think there's like interesting for historians to go back and maybe compare and contrast the roles of the media in both of those pandemics then and now. And but definitely reading about people who knew about and used lomatium being saved from the mortality that was so widespread through the Spanish flu. So lomatium is in many of the antiviral formulas that we have here on tap. We have different herbalist companies. We use BioPure. We use different boutique companies. There's a Herb Farm. There's a small boutique company around here called Woodland Essence. A lot of those companies have gotten overwhelmed, and so it's been hard for people to source these things. And so that's why I think I'm going to like more readily available mainstream. But we have Boswellia, which is an incredible anti-inflammatory for the lung. We have cat's claw is an amazing and ancient immune support. We have, of course, turmeric that's anti-inflammatory. We use sometimes these products in combination. So we have like a Boswellia turmeric combination. There's a combination that I've found online that I'm sending recommendations to people who are at home using Boswellia and andrographis, which is a bitter and anti-inflammatory that also seems to be specifically helpful, andrographis, with COVID-19. And so we've been recommending a lot of andrographis, either standalone, but mostly in a combo product that we have here called Immunomod, which also has good old vitamin A, which sometimes gets cast to the wayside, but shouldn't be. So andrographis, isatis is another one that's an incredible, I mean, I think what's amazing about the plant kingdom is that in each, like when I mentioned a few times that I had started studying plant medicine in Thailand, and there we'd use whatever's available locally. So there was a plant in Ayurvedic medicine known as amla, in Thailand is known as makam pom, that is naturally the highest food-based source of vitamin C, right? Or the bitter melon. And so depending on where we are, there are different solutions that emerge. We know that medicinal mushrooms are really helpful. We also know that the body's ability to respond to stress or resilience to stress is part of immunity, right? And so those things that are adaptogenic, and people might be familiar with different ones: Siberian ginseng, ashwagandha, rhodiola. Vitamin C is actually one of those things that has crossover because it's also very nourishing to the adrenals and is naturally antihistaminic. A lot of people might be more vulnerable because of pre-existing conditions like asthma or seasonal allergies, which make their mucous membranes more permeable. So again, quercetin, right? So we're thinking about antivirals versus anti-inflammatories, and I can there are different position statements that I've heard from different organizations, including my beloved Institute of Functional Medicine, including my brilliant herbalist colleague. And so I have these kind of lists. We think that in the flu stage, licorice and is antiviral and anti-inflammatory. That's one that's coming up a lot. And Baikal skullcap is one that's coming up a lot. Thyme is one that's a really wonderful lung anti-inflammatory. And so there's like a list, and depending on, people's familiarity with things, like that list might be changed and modified. And so, even here, rosemary seems to be one that's helpful for multiple reasons, because it's also anti-inflammatory. It has antimicrobial properties and also supports a key liver detoxification pathway called glucuronidation. Olive leaf is a natural antiviral. Astragalus, which some people argue should be part of prevention, and in some cases I'm finding is also helpful during treatment. Reishi maitake. So I think the list is really diverse, and I think that's really nice, because once something gets known, it might become out of stock, but that by no means that you can't find lots of other tools. A lot of these tools, for example, are also available in bulk herbs. So it's our common practice in this, you know, small boutique practice to just buy a lot of bulk herbs. We have just elderberry and rose hips and thyme and oregano and sage, and we just buy big bulk bags of it from Frontier spices that I buy on VitaCost, you know, a big bag of all different things for anywhere between $10 and $20, and we put it in jars and we throw it into like a French press. I'll show you here. I don't think so. Like here, this was like our just like herbal medicine mix. We can just throw tons of things into there, and we throw hot water on it, and we model how to like drink your medicine here in our office. Everyone gets a pot of tea. I think there's so many things that we can do. And depending on what you have in your home, there's also your food pantry. So there's your turmeric, or there's your curry mix, or there's mushrooms, or there's ginger, or there's just chew on a clove of garlic, for crying out loud. I mean, there's so many things we can do. And I think that's ultimately why I love this field so much, is because we are not relegated to this narrow arsenal. Like we have incredible tools at our disposal, and many of them so inexpensive. And then in terms of what I do if someone's acutely infected, well, I change the dosing. Then it should be in supplement form. Then it should be at therapeutic doses. Then I'll go to actual, you know, supplements and try to hit, you know, mega doses of things, you know. So if you take olive leaf, okay, well, maybe you have whatever 400 milligrams in a capsule or whatever it is, and however many have activated, like standardized to 22% oleo protein. But then I'm going to say, you know, take 8 of them 3 times a day if you're actively infected, and really try to knock the crap out of this virus. So I think dosing changes, but the tools are there. And I also, I think this knowledge isn't exclusive. I think this knowledge is, we have to learn how I think we can look for resources. Right now, a colleague just invited me. I actually posted it to my Facebook page if you want to take a look for people who are successfully treating COVID-19, and what tools are we using and trying to create and pull a database of this. And so my homework for tonight is to get on there and start, you know, showing what I've been doing, and then hopefully learn from colleagues and really, again, band our voices together to empower our community.
Is that an open link to that source?
Yeah. Mm-hmm. I believe
Okay.
so. I didn't have a chance to fully fill it out, but maybe that's something you can also disseminate too.
Yeah, I'll grab that link and put it on the show, on the podcast page on the website for this episode.
Oh my God, that'd be so amazing.
Yeah. So we will, just for people listening, we will put this podcast at theenergyblueprint.com/Miriam-Rahav, which is her name. So Miriam Rahav, Miriam-Rahav, theenergyblueprint.com/Miriam-Rahav. Okay. So you can look up how to spell it, or you can look at whatever you're listening to, whether you're on iTunes or Stitcher or YouTube, you can find it there. And the links will be there as well if you're on YouTube. So, and I will try to, hopefully, I'll have my team compile a list of, you know, all the different things that you mentioned there for people's reference. I'm curious, I assume you would not recommend people to necessarily use all of the items on that list, but maybe a nice assortment of them. Do you have any concern over people saying, like, I'm going to go all out with using big doses of these 30 different compounds? Is there a risk of doing more harm than good?
I think what I was trying to say earlier is that if you're starting at home and you just, like, there's so many things you can do to just protect your fundamental immunity. So let's say you take a trace mineral product, you take a little bit of glycine. Usually I see capsules that are like 500 milligrams once to twice a day. Sometimes asking for people to do things twice a day is a tall order. So at least once a day. Taurine 500 milligrams once a day. Some kind of a binder. So there's a product I really like by Biobotanical Research called GI Detox. That's a good one to take at night before bed, or if you've ever taken chlorella or blue-green algae. I love that one because it can be mixed into food. It's a one-size-fits-many. If you have IBS or gut issues, then that might not be a great starter for you, but most people will tolerate a little bit of modified citrus pectin, which comes encapsulated. I like to use a product called Pectisol, just as a general habit in the evening. It just helps kind of like the nighttime is when our body is detoxifying. Our liver is most active, according to Chinese medicine, from 1 to 3 a.m., right? Getting sleep powering down, I think we're just on our screens all the time. There's a huge association. I didn't even have a chance to talk about this with melatonin, an interesting use in quenching kind of like the inflammasome with melatonin. And so just supporting our normal circadian rhythm is like a foundational immunosupportive tool, which is
100%.
so dysregulated in all of us. I mean, I haven't even had a chance to begin to touch upon all the varying aspects of this in terms of nutrition and circadian rhythm and light and EMF. I mean, there are just so many aspects to this, which is why I think it's it can become a little overwhelming to speak to all of it. But if like I think the bottom line is kind of do what you can. So even if you don't have these tools at home, but you have the ability to power down your devices an hour early and pick up a book or a magazine, or just talk to someone, pet your cat, just make yourself a cup of tea and play on your piano or sing a song. I don't know, like something that's not a device. I challenge myself to this, sometimes successfully and sometimes not when I'm in a frenzy of communicating with colleagues about everything going on. But these are things that we can do that over time, if you are able to get out of your house and put your feet on the ground. I mean, I haven't even spoken about grounding, but it's a huge thing that I'm interested in and I'm telling people a lot about in my practice, and stand on the earth. Remember, I mentioned this very briefly, that our immune system is first electric and then chemical. I'm using the words of Clint Ober, may God bless him, and that we need those electrons, right? We need those electrons so that our immune system can work normally. And so grounding is another way to reduce inflammation. Can you put your feet on the ground and stand on the grass? I mean, I live in New York City. That is incredibly challenging to do. So it might not be for my community here, but if you have that option available to you, go for it. Yeah. I don't know. There's so many things I can say, Ari. I'm going to ramble on forever.
I'm with you. I'm a big fan of circadian rhythm, and I think that's critical as well. The melatonin link, circadian rhythm more broadly, deep sleep, and enough.
You're a big grounding. You're all about earthing, right? You're all about light.
I'm all about light. I think sunlight is huge. The vitamin D aspect is huge. There's other pathways of sunlight. I mean, sunlight also ties into circadian rhythm and sleep and melatonin. Yeah, I agree. We could ramble on forever. Dr. Rahav, this has been amazing. Thank you. I just want to extend, on a personal level, thank you again for the work you're doing. Thank you again for the courage that you have to treat these patients, putting yourself in danger and your family and your friends in danger by virtue of you being exposed to such high viral loads. I really just want to honor the work you're doing and thank you for the work you're doing. I appreciate it so much. And I can say if I personally fell ill from this, I would definitely want you to be treating me. So really, thank you so much for the work you're doing. It's so important. Thank you for helping to get the word out and give other practitioners ideas to experiment with, to hopefully advance the state of care and hopefully save some lives. I really appreciate you sharing your wisdom. Thank you so much for coming on the show.
Thank you so much for creating this space, for bringing, for all the work that you do, both personally in your own becoming the change you want to see, and then amplifying the voices of others who are contributing together to this endeavor of making this world a better place for us and for our children.
Absolutely. Thank you. Thank you so much. And also, I should mention, as a final note, if somebody is interested in either following your work or actually coming to see you to your clinic, obviously you're in New York, but do you want to just let people know where they could reach out to you?
Yeah, absolutely. So there are different ways you can find me, or also some of these suggestions that we're really just trying to put out there to support our community, our New York community, our United Statesian community, our world community. I mean, we're really trying to show up for anyone who needs us in whatever way that we can. Obviously, physical immediacy is helpful if you're sick, but we're really committed to just sharing whatever we have to share. And so we have a Facebook page where we're sharing tips. We have an Instagram. I think that's as sophisticated as we've been so far in terms of disseminating information. It would be great to do something like what you're doing at some point if I ever figure it out. And then you can also call us. We have a phone number. It's 646-503-5202, 646-503-5202. And we have an incredible team who is really, really educated and well-informed, or really good about asking me, or my amazing nurse practitioner who works here, and we can share information either directly or indirectly through our team. If I happen to have a moment, I sometimes grab the phone myself and give advice wherever I can. So
Beautiful. The name of your clinic is, if people want to look up online?
So it's the same as my last name. So Rahav, Rahav Wellness. And so we're at rahavwellness.com, and then Rahav Wellness on Facebook, and Rahav Wellness, I think 205 on Instagram. And then you can also, I'm on Instagram, and people have messaged me, our nurse practitioner, Danelle Alicio, people are NP, are messaging her directly. That's how some people are signing up for IVs, like getting in touch with us initially through Instagram and asking us what we're up to, and then calling our office. So you can find us personally. Again, we're just a small little team of individuals standing together. So it's usually not that hard to get in touch with any of us, just like you got in touch with me directly on Facebook.
Beautiful. Thank you again for sharing your wisdom with my audience. I really appreciate you coming on the show. This was amazing.
I want to thank you. I want to tell you that your work and your book on red light therapy has been sitting on in our waiting room, and has been a really popular item that people take down. And in fact, I've been thinking about ways to incorporate more in my life. I'm a little bit, real estate in New York is so precious. I would love to just have people be more exposed to your work. There's another kind of practice around us that has some red light therapy. I just would want to expose more people to it. But I'm really grateful, and at least trying to raise the bar awareness by keeping it right there on our coffee table. And I think that you are amazing. I think the work you're doing is amazing. And I
really appreciate it.
will personally love to also feature your podcast on our social media, and help you raise the bar of awareness on kinesiology, on body movement, on light, on circadian rhythm, and all of these foundations of health and wellness that you have taught me and continue to teach our community.
Beautiful. Thank you so much. I really appreciate the kind words. I also want to say, and I didn't want to, sort of interject and interrupt the flow of anything here, but just 2 days ago, I released a really fascinating podcast around methylene blue and how that may be with red light therapy, with photobiomodulation. And there's some it's very early research. It's all very speculative, but there is research showing that it leads to inactivation of coronaviruses. That's been shown. And then there's a brand new study, it just came out a few days ago, showing that it leads to inactivation of this new coronavirus strain. So I'd be super curious to have you listen to that and maybe even start experimenting with it. And I don't know the, sort of the legal aspects of what you can and can't experiment with, but if you can, I would love to hear, feedback on if it's effective or not.
Yeah, I wonder also, like in terms of your work, the fact that we've repeatedly used, and we've had amazing, just unbelievable clinical scenarios outside of COVID with a combination of use of ozone with ultraviolet light irradiation, so also known as Photox therapy. I mean, if I start telling you the stories, they're really staggering. Also in terms of autoimmune and reduction of flares, also in terms of blood flow, which is also something that you might know in terms of grounding, that neutralizing body voltage will lead to like blood flow. But when we use light therapy in combination with ozone with that, we had a woman show up with mesenteric ischemia, which is like a blockage similar to a blockage of your coronary arteries, where you then can get a heart attack and die. You have a blockage to an artery feeding your intestines, right? And so your intestines are exercising when you eat. So like you get, after you eat, like this excruciating pain, which means you can't eat and the doctors were recommending her to get a stent the way you do for a coronary stent. And she happens to be a relative of someone who knows our practice, and he called and he said, "What can you offer for this?" And I said, "Well, I know that this combination of light and ozone normalizes blood flow. So why don't we see after 1 therapy, she felt better. After 3, she was completely asymptomatic and was able to avoid stenting of her mesenteric artery.
Wow.
So, I mean, I think we're seeing, so just in terms of validating like the power of light, again, in combination, the photox, and again, I'm standing on the shoulders of giants who put this thing together. I think there are some medical legal, I think, aspects with me rolling out things newly. Like, I think I could do it on myself. But in terms of experimental treatment, I mean, there would be a consent, and I think I'm dealing with people who are fearful and in a state of emergency. And so, you know, if I didn't have other things that I'd already practiced and had already been proven and that were kind of more widely used, it would be a big question mark, you know, in terms of justification if there were already other things that were working. But I still think it deserves clearly attention. And I mean, that's what we use if we talk about the pathophysiology with oxygen and how we deal with carbon monoxide poisoning. That's where methylene blue comes out of. It's like, you know, so it's a board exam question. Like, what do you do?
Yeah, it's funny. I've heard that in a number of conversations that I've had with doctors. They're like, it's a board exam question. Yeah. Well, thank you again. This has seriously been awesome. And really thank you for the work you're doing. I appreciate it.
You're awesome. You're awesome. And I can't wait for the next time we get to chit chat.
Me too. Thank you. Hey there, this is Ari again. One more quick thing before you go. Just make sure to subscribe to our YouTube channel, The Energy Blueprint, and also make sure to subscribe to this podcast on your favorite podcast platform, whether that's iTunes or Stitcher or anything else. I hope you guys enjoyed this interview, and I will see you again next week.